of the Council of Deans, and in order to obtain the degree of Doctor from Rabot University Nijmegen, I would like to defend in public my doctoral thesis entitled Healthcare Provision Open for Business, Market Dynamics, Performance and Ethics of Commercially Oriented Healthcare Providers using the Netherlands as a case study. The commercial sector has grown over the years in many healthcare systems. The growth was mainly driven by an idea called New Public Management that became popular in the 1980s. New Public Management argued that public organizations should be run like businesses to make them more efficient, improve responsiveness, and spur innovation. This led governments to embrace privatization and competition in the provision of public services, including in the healthcare sector. Some countries have put this in practice more than others, as this map shows. There are more commercial for-profit healthcare providers in some countries than in others. There are also differences by sector, for example between hospital care and nursing home care. The Netherlands also introduced healthcare reforms inspired by new public management. However, we know very little about how commercially oriented providers in the Netherlands behave in practice. This thesis addresses this knowledge gap. It looks mainly at the Netherlands, but also makes international comparisons to learn from experiences abroad. There are three types of ownership in the healthcare sector. Firstly, there are publicly owned healthcare providers. Secondly, there are for-profit providers, which are private entities that can allocate profits to shareholders, and in return, they receive private capital investments. Non-profit healthcare providers are private entities, but unlike for-profit providers, are not able to allocate profits to third parties. They need to reinvest their profits in their organization. We can make a distinction between commercial non-profits and non-commercial non-profits. Commercial non-profits act like commercial entities and receive income from providing services and have to compete to do this, whereas non-commercial non-profit organizations receive most of the income from grants or donations. This thesis focuses on for-profit and commercial non-profit healthcare providers. These are what we call commercially oriented providers. The main research question of this thesis is, do commercially oriented healthcare providers contribute to a qualitatively better and financially sustainable healthcare system? The supporting sub-research questions are, what are the market trends that explain the growth and/or performance of commercially oriented providers? How do commercially oriented providers perform regarding cost, quality, and accessibility compared to the traditional sector? And what ethical issues arise from the provision of healthcare services by commercial organizations? This thesis uses both quantitative and qualitative methods, so interviews. We use techniques, perspectives, and theories from disciplines of economics, public administration, organizational science, ethics, and history. This thesis looks at three sectors: hospitals, independent treatment centers, and nursing homes. Hospitals are defined as entities that provide specialized medical treatments. In the Netherlands, for-profit hospitals are almost non-existent. More on this later. You may be unacquainted with independent treatment centers, or ITCs. These are clinics that perform common elective, so non-emergency surgery. Often ITCs focus on one type of treatment or patient group, such as cataract surgery. ITCs are commercial entities and can be either for-profit or commercial non-profits. ITCs have grown significantly in recent years in the Netherlands, as this graph shows. Nursing homes are defined as entities that provide long-term care for people in need of 24-hour care. We found that the number of for-profit nursing homes has grown significantly in the Netherlands since 2015. So the results. Our first case study is the hospital sector. We studied the relative performance of commercial versus public hospitals using a systematic literature review. We found that there isn't a clear difference in quality between them. However, we did find that for-profit hospitals are less accessible, meaning that patients with higher socioeconomic status, private insurance, and with less complex cases have an advantage in accessing for-profit hospitals. We also found that for-profit hospitals are more responsive to external incentives than their public counterparts, which means that for-profits are more prone to provide treatments that are financially beneficial. Contrary to economic theories, we also found that private, non-profit and for-profit hospitals do not outperform public hospitals on efficiency. Efficiency means with less input, for example fewer staff, the same or more output is generated. And by output, I mean the number of patients treated and/or quality of care. So, if efficiency is not the main driver why the for-profit hospital sector has grown, we therefore looked at other factors that might explain its growth. And we studied the phenomenon in the US, UK, Germany and the Netherlands. In the US and in Germany, the for-profit sector has grown steadily, as this graph shows. In the UK, the growth has stalled, while in the Netherlands, the for-profit hospital sector is almost non-existent. Why these differences? We found that it is access to and generosity of public reimbursement schemes that best explain the rise of for-profit hospitals. In other words, the way hospitals were paid for services and capital explains why for-profits have grown in some countries but not in others. The political environment, so whether the ruling party is on the left or the right, is less important, as you can see in the graphs. Our second case is the independent treatment center sector. When we compared ITCs with general hospitals, we found that the contracted prices are lower among ITCs. And in the case of cataract surgery, ITCs appear to be more efficient than general hospitals. We did not find clear differences in the quality of patient outcomes, but we did find better patient satisfaction. However, we found some possible signs of ITCs treating patients more than necessary. Our final case study is the for-profit nursing home sector. We found that the number of for-profit nursing homes has grown significantly in the Netherlands since 2015. Several factors explain its growth. Firstly, the institutional environment has changed. Since 2015, the government started to split finance of care and housing, and that strategy fits the business model of for-profit providers. Secondly, for-profit nursing homes appear to be less responsive to demand, whereas for-profit providers have tapped into a demand for small-scale, home-like nursing home facilities. And thirdly, for-profit providers have been able to cherry-pick by selecting more profitable clients. This thesis also analyzed the for-profit nursing home sector from an ethical perspective. There's a long-standing debate among academics about whether money erodes intrinsic motivation, care, or love. We contributed to this debate by interviewing stakeholders in the for-profit sector to explore their values and motives. To put our findings in a nutshell, we found that having commercial interest does not necessarily erode or undermine the nursing home caregiving and professionalism. This is because the values and motives of stakeholders differ between the different layers of the system. Managers and owners of for-profit homes tend to talk more in market terms, and nurses appear to uphold those market values less. So the conclusions. The conclusion of this thesis is that commercially oriented providers have the potential to contribute to a qualitatively better and financially sustainable healthcare system. They present some opportunities and some risks. In terms of opportunities, the commercially oriented providers can access large capital funds, they're often more responsive to demand, and they achieve better client satisfaction. On the flip side, commercially oriented providers come with risks such as cherry picking, overutilization, and sensitivity to financial incentives. And both the opportunities and risks have spillover effects for traditional healthcare providers. However, the sector is diverse. There are different degrees of commercialization among providers, and highly commercialized providers that tend to focus on making profits rather than on providing care come with higher risks. To conclude, we need to differentiate the commercially oriented healthcare providers, such as identifying the highly commercialized sectors and entities and focus on regulation and oversight on these. Having presented this summary of my thesis, I return the floor to you, Rector.
Okay, thank you very much for